Hello, and welcome to the research presentation on the research collaboration on chronic conditions conducted by the University of Bologna and the University of Newcastle. What I'll be presenting today are two projects that we've been working on that look at the chronic management of diseases and in particular focuses on chronic kidney conditions within a particular region. This collaboration has been conducted in partnership with Ayman Fouda as part of his PhD, Professor Francesco Paolucci from the University of Newcastle, and myself, Dr. Naomi from the University of Bologna. In addition to these three co-authors, we've also been working in partnership with Professor Fiorentini from the University of Bologna, Professor Luke Connolly from the University of Queensland, Australia, and Marika Naomi from the University of Bologna in Italy. Chronic diseases, or non-communicable diseases, known as NCDs, are responsible for the largest share of morbidity and mortality in developed economies, including Italy and Australia. NCDs have replaced communicable diseases as the major culprit for morbidity and mortality in the last few decades, especially in developed countries or economies. They have accounted for approximately 10% of premature deaths in Italy and 9% of premature deaths in Australia. There have been a number of reforms in healthcare systems around the world, and they have focused on tackling NCDs in the last few decades. These have included financial reforms and organizational and service delivery reforms. When it comes to reforms, the regulators have objectives which include achieving the best possible outcomes for healthcare services and to optimize the delivered services at the least cost. Regulators tackling NCDs are faced with the principal agent problem, and in our case, a multiple principal agent problem, where service providers are the agents to two different principals. In this case, the service and regulator or the payer are the first principal, and the second principal are the patients. As a part of the University of Newcastle and the University of Bologna collaborations, these projects focus on NCDs. As the Organization of Health Services in Italy are regulated at the regional level, we study a specific chronic disease management program in the region of Emilia-Romagna. Each region of Italy has its own regulations and resources allocated to health. That is why we specify only one. The scope of the study, or the studies, are to examine the institutional settings and the regulatory economic arrangements in light of the multiple principal agent interaction occurring. Both of the projects that we are working on have been conducted as part of a PhD student's thesis. The first one is a case study on the organization and entry of a chronic disease management program in Italy. The second one looks at the institutional effects and prescribing behavior in a chronic disease management program in Italy. For the rest of this presentation, I will describe the overall aim and objectives of each of the two projects, and in the case of the first study, we'll be able to provide some of the results that have already been found. As for the second, it's still a work in progress, so hopefully you'll be provided with another update via a full working paper in the near future. The first project had the aim of presenting a case study of the organization and entry of a chronic disease management program in Italy. This project is a PhD thesis project led by Ayman Fouda for his PhD thesis. This program was known as PIRP, P-I-R-P. The Chronic Kidney Disease Management Program is based in the region of Emilia-Romagna, and it is financed through taxation. It is organized by the Health Region of Emilia-Romagna, so they are the ones responsible for this data set. The dataset was started collecting in 2004 under the guidance of the University of Bologna's Medical University. It had a mission to early identify and manage CKD patients to prevent or slow disease progression to terminal stages. The program adopts a co-management model of care of patients between general practitioners and specialists. Now, the three key players in all of this are the regulators, so the Health Region of Emilia-Romagna. They are also one of our principals. The second one is the chronic kidney disease patients. They are also our principals. And then finally, as our agent, we have the service providers, the specialists and the general practitioners. To keep it brief, we'll now go on to discuss each of the three key players and the key findings that we had in this first project. Some of the key findings of Project 1 are now presented. When we look at the patients, CKD patients might be comorbid patients, so where they have one or more communicable diseases besides chronic kidney disease. Patients with CKD usually suffer from other chronic conditions such as cardiovascular diseases, diabetes, hypertension, and so on. Those patients are usually followed up by different specialists and GPs. In addition, services are generally for free except for co-payments for prescriptions and outpatient consultations. As the service is publicly financed mainly through taxation, PERP enrollment is generally free of charge except for co-payments that patients have to incur due to national regulations. In this case, patients have to share the cost of services like prescriptions and out-of-patient visits. PERP is seen as a superior good by the patients as it provides a higher level of care than if they were not enrolled. Therefore, a patient's utility would be maximized via enrollment in the PERP program. Key findings for the regulators were that patient enrollment into PERP is guided by local clinical practice guidelines, which follows the KDIGO guidelines. KDIGO stands for Kidney Disease Improving Global Outcomes. To optimize the enrollment procedure, the regulator issues enrollment guidelines that follows the international standards. This is run by a global non-profit organization dedicated to the tackling of kidney diseases. In the case of CKD, there are 5 stages of chronic kidney diseases where patients are enrolled into PERP if they are in stage 3B or stage 4. Other stages should not be enrolled according to the guidelines. Due to the limited amount of resources, the regulator dedicated a predefined and limited bid to PERP. Therefore, patients have to be appropriately qualified to enter the program, as we have a restriction on the number of beds available to CKD patients. And additionally, the model of care or co-management is that it is shared between GPs and nephrologists. Finally, we have the specialists. As CKD patients are largely comorbid, there may be interprofessional competition occurring between the different specialists, so in this case, nephrologists, cardiologists, and endocrinologists. This competition is to control the decision-making process and the jurisdiction of the patient and hence increase their own market share. Finally, as GPs in the region are under the competitive pressure from their peers, GPs may tend to satisfy their patients by referring them to PERP, which is perceived to be a superior good compared to non-PERP services. So this may end up affecting enrollment whether they are actually qualifying for the PERP guidelines or not. I will now move on to the second project. The second project is also a collaborative piece and will be part of Ayman Fouda's thesis. The aim of the second project is to examine a physician's decision to prescribe generic or branded medication. A physician's decision to prescribe generic or branded medication affects patients, pharmaceutical providers, and prescription providers. In the first instance, a prescription decision will impact the patient's individual healthcare costs. In the second, the price competition between pharmaceutical providers will be affected. And then finally, it actually impacts the providers, the physician prescribers' budget for pharmaceuticals. The aim of this research is to investigate how a professional healthcare practitioner behaves when choosing the prescription medication, in this case, branded or generic for an individual. We follow a multi-principal agent theory to investigate the influences of prescribing behavior for generic or branded medications by general practitioners. In our setting, we have practitioners who act as agents for 2 principals, their patients and their payer. We predict that the environmental factors and the principal preferences will play a significant role in the share of generic medication prescribed by the general practitioner. By examining the literature in the health system environment, we determined the following areas to be of interest to understanding prescribing behavior. Overall, these 3 areas of interest on prescribing environment can relate to both the supply and demand side factors. So we have the institutional settings and regulations, where the demand side costs or the co-payments of the patients are internalized, along with the socioeconomic standing of the patients, and whether the involvement of specialty practitioners influences the branded or generic choice of prescription. The first are the supply constraints, where the institutional setting may incentivize specific behavior. And then we have two demand side effects, which could influence the prescriber. Using regional data, which includes the medication type prescribed, we will investigate the influences of GP prescribing behavior. We hope that the findings from this research will be used to inform CKD prescription management and guide policymakers on the reforms for prescription medications. Thank you for listening to today's discussion, and we hope to be able to provide you with more updates on our research in the near future.